Good morning, everyone. I'm Fabrice Borlesi. I'm the medical director and head of clinical research in Gustave Roussy in France. And I'm really happy to join you for this conversation about the next wave of immunotherapy.
Yes, thank you. Good morning, good afternoon, Professor. And everyone, welcome to Axiom Healthcare Strategies ASCO Town Hall on the next wave of immunotherapies for cancer. My name is Ann Cherry, Director of Axiom Healthcare Strategies, and I am honored to introduce this morning Professor Borlesi. He's a lung cancer physician by training, but he is deeply involved in next generation cancer immunology research, and that's what we're excited to discuss with him today. Before I turn it over to Professor Borlesi, though, I want to give our viewers a quick overview of the technology on today's conversation. So first of all, we will be recorded. So the town hall will be available to view after the fact on the Axiom Healthcare Strategies YouTube channel later this week. And because it is a town hall, we want this to be an interactive experience. We invite everyone to ask questions, which you can do through the question and answer bubble that you'll see at the bottom of your Zoom screen. And I'll be keeping an eye on any questions that come through, and we'll try and address a couple questions for each of the MOAs that we discussed today. So if we go to the agenda slide here, a general outline of the conversation. Professor Borlesi is going to open it up with his perspectives on what we know and what we don't know about IO resistance. Then we'll talk about new data from ASCO 2020 in some key MOAs. We're going to be talking about Tgf-Beta, TIGIT, LAG-3, and then a couple of IO bispecifics. Now I'll be joined by my colleagues, Hafiz Sikter and Faisal Khurshid. We'll be joining the discussion of these new data from ASCO. So again, welcome. Please feel free to submit questions, and we will do our best to cover them during the course of the discussion. So Faisal, over to you.
Great, thank you, Anne, for setting up. Thank you, Professor Borlesi, for joining us all the way from Paris, France, in your afternoon and our middle of the day. So we'll start with just the discussion of some of the key data. But I guess before we jumped into that, Dr. Borlesi, it would be great to just hear just some of your perspective on where we are with IO as a whole. What is the latest understanding of what needs are filled with IO? Where does some of the unmet need or resistance stay on? And what is really the crux of why we need this next wave, or what it means when we say that we need a next wave of novel immunotherapies?
I believe that we made, I would say, large progresses in the field and in the use of IO, especially if we focus on the lung cancer as an example. We can see that IO has now a place in many different settings regarding the management of lung cancer. We have some very exciting data in the early stages, even if we don't have any approval, but we have a place in the local regional diseases, a place in the advanced stages in combination with chemotherapy, or alone in the first line, in the second line setting, but also in the small cell lung cancer. And I feel that we have found a place for immunotherapy, but we still have a lot of challenges regarding the use of immunotherapy. I think the big one is probably to be able to identify the patients' populations who are benefiting the more from the immunotherapy that we have in our hand as of today. And to do that, we have to find probably better biomarkers to understand the mechanism of progression, the distribution of this mechanism of progression, and then it will allow us to better understand why we have some patients who are primarily resisting to the immunotherapy that we use today, and some who are presenting with secondary resistances. And when we will be able to understand this point, then we'll be able to draw the new strategies based on the mechanism of action and the drug that we will see in the next couple of minutes. And I think that it will help us to provide the patient with an additional possibility to benefit from this long-term overall survival benefit that we all expect for our patients with immunotherapy.
Got it. So as we go through some of the key data, we've selected 4 key topics that we wanted to probe you on and just go over. And as we go through these, then I guess it will be good for us and for the audience as well to just keep in mind of, how do these, or to what extent do these have promise to extend survival and extend just the magnitude of benefit that IO provides, both in terms of the breadth of number of patients that can benefit, as well as the depth or longevity of benefit that can be provided. So thank you for some of that context and introduction. So we'll go through 4 broad topics here. We'll aim to spend about 10 minutes each on just some of the data, and would be helpful if you could put it in context for us and help us understand some of the key points here. So the 4 topics we'll cover is TGF-Beta. We've seen a couple of new agents in this class, but the one that's kind of leading the way is a bifunctional agent called bintrafusp alpha. Then we'll go to the TIGIT class. This is a hotly discussed area lately, where we recently saw some randomized phase 2 data, which is always interesting to see from a novel agent called tiragolumab. And then we'll go into LAG3, where there's a few different ways of hitting the same mechanism or the same target in the immune system. And then lastly, this topic of IO bispecifics, which appears to be an area or a trend that's getting more and more interest and some more advanced approaches there. So exciting discussion ahead, and then we'll have plenty of time at the end for Q&A. So audience, please feel free to submit your questions on the Zoom system. So with no further ado, we'll jump right in with TGF-Beta, and specifically discussing bintrafusp alpha. So Dr. Barlesi, to start, it would be great if you could just talk a little bit about the role of TGF-Beta, and then really what is this agent doing in the immune system, and what type of benefit with regards to the immune cycle can we sort of expect here?
Of course, I think it's a very interesting drug, and I think we all know from our medical courses the role of TGF-Beta in a lot of different diseases, and especially we came back to this data when discussing the immunotherapy and how the immunotherapy works, and we know that TGF-Beta has a major role as a suppressor of the immune response, and also is influencing the tumor microenvironment. But we know that alone targeting the TGF-Beta would probably be insufficient. And given the place of the PD-1 and PD-L1 inhibitors, it was logical to try to combine the 2 mechanisms of action, at least the blockage of these 2 different pathway, largely influencing the action of the immune system on the tumor. And it's how the bintrafusp alpha has been set up. It's both TGF-Beta trap and the PD-L1 inhibitors, and it has been developed in order to be able to address these 2 different targets from the microenvironment. And we had the first results of this drug presented 2 years ago, if I'm correct, during the SITC. The first results were presented. And if we move to the next slide, we can see the 2-year follow-up of this drug, which is then a fusion protein targeting both, as I said, the TGF-Beta and PD-L1. And this study was conducted in the second-line treatment of non-small cell lung cancer. And as you can see, the recruitment of the patients was based on the selection of the patient was based on advanced non-small cell lung cancer. Patients were recruited regardless of the PD-L1 status, and they have progressed after first-line standard of care, which was, as you know, platinum-based chemotherapy, and those patients had to be IO naive when they have been included. And they have been randomized 1-to-1 between 2 different levels of the drug, either at 500 milligram or 1200 milligram every 2 weeks. What is interesting, as you can see, or maybe just guess on the slides, on the figure on the right, is the activity of the drug, and you can see on the curves that there is an activity of the drugs. You can see that if we look at the median overall survival in this for these patients. The median overall survival for the vast majority of the patients, irrespective of the PD-L1 status, was clearly greater that, compared to what we can expect with the standard of care that we had previously, or what really, I would say, in line with what we can get with the immunotherapy. We can see on the top of the curves, the patients with the high PD-L1 expression. As you can see, the number, the assessment of the PD-L1 status was done using a specific assay, which is not the 22C3. It's why you can see that it's for the patient with more than 80%, which in fact is probably close to what we know for the patient with more than 50% of PD-L1 expression using the 22C3. And we can see that in these specific patients populations, the activity of the drug seems to be a little bit higher. Of course, the number are small, and it's subject to confirmation. But once again, if we look at the activity of this drug, we can see that we have an activity that is clearly efficacious in all the different types of patients, and seems to be a little bit better than what we can expect with our previous standard of care. If we look at the tolerance of the drug, I would say there was nothing unexpected regarding the tolerance of the drug and the safety profile. We observed what we expected regarding the use of immune checkpoints inhibitors in this population, with some pruritus in the main adverse events were pruritus or rash. We had some general adverse events like the decreased appetite and the asthenia, which is something usually reported. Regarding the more severe treatment-related adverse events, it occurs in less than 30% of the cases, and only in 2 patients for the grade 4 treatment-related adverse events. With a longer follow-up, I would say, no additional severe events were reported. And as you know, one of the specificity regarding the Tgf-Beta blockade is related to current acatomas, and it was reported, but the patients were very closely followed regarding this risk, and only grade 1 additional cutaneous lesions were reported in this analysis. Then globally, I would say that we have a drug with an innovative mechanism of action, a mechanism of action that may overcome some of the mechanism of resistance that we have regarding the PD-1 or PD-L1 only blockage. The overall survival is, I would say, reaching our expectations regarding the intensity of the activity. We can see that we have probably with this drug, if you look at the beginning of the course, we have maybe less risk of earlier resistance to the drug. Maybe it's related to the double mechanism of action, and we have this proportion of patients. If we look at the end of the curve, we have a large proportion of patients still alive after approximately 30 months of follow-up. Then I think it's an interesting drug, and we have to follow the next results we are waiting. As you know, some randomized trials are ongoing right now.
Right. Thank you for that wonderful overview, Dr. Palese. I guess one of the main questions that comes to mind is, as you pointed out, that this is a study that was initiated some years ago before PD-1 therapy really was the accepted frontline standard of care, right? So now, patients who are eligible for IO therapy are typically getting this earlier in their treatment course, which is not the case in this study. So I guess as you interpret these study results, how do you sort of reconcile that in a way? Do you kind of cross compare this to studies like Checkmate 17 and 57 to see how that compares? Or and I guess with that type of comparison, do we know that this is really providing something above and beyond what we might expect with a PD-1 or PD-L1 blockade alone?
As you know, it's really difficult to do this kind of cross-trial comparison, and I think giving this, we are clearly in an early phase trial with this drug. We can consider that the results are quite solid regarding the length of follow-up for these patients. I think the data favorably compares to the data that we have with the PD-1 or PD-L1 inhibitors. Globally, we have a median overall survival of more than 13.6 months, which is something that is appreciable. I have to remember we are in the second line setting, but there are two different questions regarding this cross-trial comparison. First, of course, it's not, I would say, a selected population. And the second point is that our environment changed in the meantime. And now we have, it's really difficult to I would say, have an idea on how these drugs may be precisely used, then what are the characteristics of the patients or the tumors that may drive the use of these fusion drug compared to a monotherapy, and what are the predictive biomarkers that we may choose in this field, how we can analyze the tumor or the blood of these patients, and how it could be used in order to reverse any resistance to the immunotherapy that we have on our hand, and how the use of a combination of chemo and IO or chemo with this kind of with this drug may provide an additional benefit regarding the strategy that we have. Then it's opening a way, but we have probably to try to understand the best as we can how to precisely use this drug. And I think it's the challenge that we have with all the new drugs that we have in our hand right now.
But that's going to be my follow-up question is, based on what we've seen so far, which patient population are you most excited to try this new Tgf-Beta therapy in?
I would say probably it's in combination with chemotherapy, and probably I would say if we believe and once again it's cross-trial comparison, but if we look at as an example, the keynote data that we have, and if we look at the keynote data in the second line setting and in the first line setting, it seems that the risk of resistance is probably greater in the second line setting compared to the first line setting. Then probably using the most potent drug that we may have as early as possible is probably the best way to use the drug. Then probably moving very early is interesting with this drug. Probably moving in the locally advanced disease is probably very interesting with this drug, and trials are ongoing. And maybe moving with this kind of drug in the early stage setting, combined with surgery, maybe also something very interesting. Then I would say globally, probably the mechanism of resistance are developed by the tumor during the different stage of development, and to face the different treatments we are giving to the patients, and probably using it very early, as early as possible would be the best way to use it.
Got it. Great. Thank you for that overview. And my understanding is that this is in a phase 3 trial right now in the frontline setting, head-to-head versus pembrolizumab, which is a very interesting approach that we would be excited to see
Absolutely.
when those results read out. Okay, great. So then, Dr. Bellesi, we'll move on then to the next topic here, and this also is as you know, a very actively discussed area now. This idea of anti-TIGIT antibodies as a class of molecules, given that we saw some randomized phase 2 data of anti-TIGIT from the Roche Genentech group called tiragolumab, combined with a PD-L1 antibody compared head-to-head versus the PD-L1 treatment alone in a frontline PD-L1 selected lung cancer population. We'll go into the data next, but I guess before we do that, it would be helpful just to hear your perspective on this class of antibodies, this anti-TIGIT class, and what is it doing in the immune system, and what benefit could we expect it to provide on which immune domains and what mechanism?
I think it's quite clear for everyone that there are a lot of different checkpoints, and we have seen this kind of figure a lot of time during the presentation, and we know that we have different checkpoints that may influence the response to the activity or the efficiency of the immune system. And one of the difficulties that PD-1, PD-L1 is representing one of these checkpoints, but may be insufficient to be blocked if other kind of checkpoints are already activated or are already driving the resistance to the immune system. The second point is it's becoming clearer and clearer that the native immune system is also playing a great role in fighting the cancer cells, and then all the strategies that may provide a more comprehensive blockage of the checkpoints, but also maybe able to engage different types of immune cells, both the T cells, but in this case also the NK cell, would be probably interesting to look at, even if at the moment we don't have any idea on the type of biomarkers we may use in order to select the use of this drug, but it's something that is done in parallel of the trials with the translational research program that is integrated in these clinical trials. Then it's why I would say, and we will see several examples of this kind of strategy, but clearly this type of strategy is very interesting today.
Got it, and that's an interesting point on the activation and involvement of the innate immune system as well with this type of an MOA. In terms of the data here, it's one of a more unique situation where we get this nicely designed randomized phase 2 study with, hopefully easier to or more clearly interpreted results here. So would be great to just hear some of your analysis and interpretation of some of the key data points. We have here the PFS Kaplan-Meier curves, and there was also data shown for response rate as well.
Yeah, I think it's what we discussed just before. Then one of the bet of the investigators and the sponsor of this trial was to go as early as possible with this new drug. Then I think they designed the trial, including first line stage 4 non-small cell lung cancer without any oncogenic addiction. And they selected the patients based on the PD-L1 status, providing they have at least a PD-L1 expression of at least 1%. If not, we can emphasize the fact that it's maybe one of the first trial assessing atezolizumab, but where the patient selection was done based on the 22C3 assay, which is, I would say, probably more widely used, and then I would say that will be maybe easier to convert these research results in daily practice. Then they selected the patients based on the PD-L1 status, providing the tumor is expressing PD-L1 in at least 1% of the cells. And patients were randomized between atezo at the standard dosage or tiragolumab or placebo. Tiragolumab was used at the every 3 weeks as for the atezolizumab. And there was no crossover allowed in the study. And the patients were treated as it is the case in all the atezolizumab study until progressive disease or loss of clinical benefit. Then the co-primary endpoint of the studies were the response rate and the progression-free survival. If we look at the overall populations, we can see that there was a benefit regarding the progression-free survival, and the median progression-free survival was 5.5 months for the combinations of the tiragolumab and atezolizumab compared to 3.8 months for the atezolizumab only, and it was statistically significant. Of note, we can see that there are still some, I would say, early progression or primary resistance to the treatment, as assessed by the fact that during the first 2 months, we have approximately 1/3 of the patients who progress on immunotherapy only, but it seems to be a little bit lower quite early for the combination arm, maybe highlighting the fact that the combination is adding something in order to overcome the potential mechanism of resistance. And it seems to be particularly true if we look at those patients with the highest PD-L1 expression, more than 50%, as you can see on the figure, at the bottom, we can see that there is an early separation of the curves. It seems that the progression-free survival, even in the patients, in these selected patients populations on the PD-L1 inhibitors only, these patients are facing some primary resistance. As you can see, at 2 or 3 months of treatment, a large proportion of these patients, approximately 1/3, have already progressed, but it was not the case for the combination arm, where it seems to be a low rate of early progression and early resistance, and it translates in a large progression-free survival benefit. The median progression-free survival was not reached for the combination arm, and it was 4.1 months. Then I would say very comparable to the 3.9 months that we have in the intention to treat population, and it was highly statistically significant with an hazard ratio of 0.3. Then I think it's probably a little bit too early to draw any firm conclusion, but the signal here seems to be that there is an advantage in the combination, and especially in those patients with the high PD-L1 expression, the advantage seems to be very important. We will have to see if it translates in an overall survival advantage, of course, which is very important. But if the tail of the curves is like that with a longer follow-up, it will provide, of course, a potential clear new standard of care in this patient's population. Once again, we will have to identify how we can select this patient's population and identify the patients who are deriving the larger benefits. Looking at the safety profile, which is of course important, we can see that there is an increase in the number of adverse events when using the combination. The type of adverse event is clearly, I would say, represented by immune-related adverse events, and in the vast majority of the cases, these adverse events are of grade 1, but we can see some grade 2, and especially regarding the risk on infusion-related reactions. And also, I would say all of these aspects regarding the general status of the patients, especially the fatigue and the cutaneous adverse effects, which may be of importance in treating those patients. And I think it's something that we'll have to take care in the future, in the future clinical trials, and maybe also in the way we will use this drug in the future, at least the combination in the future.
Got it. Thank you for that overview, Dr. Barlesi. In terms of some of the points we wanted to discuss, you did mention, or you did address this first one around, you'll want to see that longer follow-up, see how the PFS tails of the curve hold up, and ultimately await an OS benefit. One of the actively discussed features of the data set that I wanted to ask you about was this idea that, in terms of the shape of the curves and splitting out the PD-L1 1 to 49s compared to the 50% and higher, you kind of saw something not dissimilar from what we saw with Keynote-42, really, where the overall intention to treat results were positive, but really the study was carried primarily by that PD-L1 50% and higher. I guess just curious for your interpretation of this. Is this something that's expected? Is it disappointing at all? And what does this mean for, I guess, what you would predict the impact this class of antibodies might have moving forward as it enters pivotal studies?
You're right. I think when we have seen the results of the Empower 110 study with atezolizumab in the same context as the patients treated in the Keynote 42, we can see that the results were really comparable. I think here, if we look at the control arm, the results are also, I would say, globally in line with the results we have seen. And I think what is, I think, very important when we are discussing the immune checkpoints inhibitors, in all the data, almost all the trials that we have, it was really difficult to show a clear benefit when looking at the PFS curves. The main differences were seen in the overall survival curves. And I think here to my opinion, it's quite rare to have such a difference regarding the PFS curves if we look at, especially at the group of more than 50%. I don't know if in the intention to treat populations, the majority of the benefit will be driven by this higher expressor. It's possible. We'll have to see. But I think it's probably that something is happening, and probably if we are able, it seems that of course the benefit is larger for the PD-L1 expressor, but maybe there is also another population that we are able to rescue regarding the combination compared to atezolizumab only.
Got it. Okay, great. I know we have some questions coming in from the audience. Also want to just remind the audience that they can submit their questions on the Zoom system. In the interest of time, I would suggest that we move on, and then we can come back to some of the questions at the end, hopefully time permitting. So the next topic that we wanted to dive into was this idea of LAG-3, and it's another immune checkpoint. One of the interesting features that we wanted to ask about was this idea that you can utilize LAG-3 in a few different ways, where we have seen two different types of molecules in development of LAG-3 inhibitory antibodies, as well as LAG-3 fusion proteins that would act in a markedly different way. Just curious, Doctor, on your perspective of this mechanism of LAG-3 and these different ways of hitting the target, and whether one might be better or worse in different situations than another.
First, I have to say that it's with I say a huge respect for the people from Gustave Roussy, because you know that this drug has been discovered here in Gustave Roussy in the 90s and then developed more largely, of course. But I think it's an illustration on how the translational research in big comprehensive centers may translate quite quickly, I would say, in not only one drug, but many types of drugs. And it was something that I would like to point out. But you're right. Once again, it's another immune checkpoints. Once again, it's I would say an interaction and a checkpoint that may explain some of the exhaustion of T cells, and it's why a large part of our attention was focused on these molecules. But we still have a lot of things to understand on the different types of interaction of these drugs and the different what could be the impact of the blockage on different type of cells and how globally it's influencing the tumor microenvironment and the activity of the immune system. The different types of drugs that have been developed and with the results presented during the ASCO meeting is of course also very interesting. It translates, I would say, the different modality of blocking this target. I'm not a specialist in the drug development. It's very difficult to draw any conclusion or even to have a sign regarding these studies regarding what could be the best type of drugs in order to block LAG-3. But it's I would say interesting as a clinician to see that we have all these possibilities, and maybe all of them or some of them will become a potential treatment used in clinical practice in the future.
On the next slide here, we had a few just an overview of just to show the audience just the breadth of LAG-3 agents that are in development, where you know, it's one target but multiple ways to hit the target, where there's kind of classic inhibitory antibodies in development by the likes of BMS, Novartis, and Merck, as well as BI. There's bispecific DART molecules, as well as soluble fusion proteins, such as the one from a company called Immutep. So we'll go through a couple of these data sets, Dr. Barlesi, and we'll just be curious for just the quick interpretation of these. So the first one here, we have the BMS antibody relatlimab. And I know there's a phase 3 study in melanoma ongoing, but in the meantime, there was this interesting investigator study, phase 1, looking at the combination of the LAG-3 and PD-1 in GBM, which I guess is not an area where we typically see much IO activity. So I guess just curious your read on this study and interpretation of what we saw here.
I think that well, it's we all know that the use of immunotherapy in this disease is quite disappointing, I would say. Then I don't know if it's related to the drug by itself, to the design of the study or the disease. And I think we have to wait for the other results. For instance, in this specific tumor model, it does not provide with any advantage to combine the LAG-3 inhibitors with the PD-1 inhibitors, or at least the addition of the PD-1 is not providing any additional activity. But I would say that one of the issues is that we don't know exactly how the LAG-3 checkpoints is involved in this situation and in this disease, and then it's probably why it's difficult to draw any definitive conclusion.
Got it. Yeah, and I think you know, one of the things that you mentioned earlier as well was this idea of selection of the patients. What is the kind of idea of what is the right place and right time for novel therapy that you're trying to fit in to a treatment paradigm? So you know, there's a similar trial design happening in frontline melanoma, I believe, where it's a LAG-3 and a PD-1 compared to PD-1 alone. So will be interesting to see if those results look different than what we see here.
Yeah, clearly we'll have to see that. And I think we have also, for the moment, we don't have, I would say, a large, large atlas regarding the immune, the characteristics of the tumor microenvironment and the tumor regarding the distribution of all these, the activation or the inactivation of these different pathway and checkpoints. Then in order to know if there is an interest to use monotherapy or combination therapy and what kind of combination of therapy, just in order to be more precise in our use of this drug and not just trying to, in different tumor types without any biological selection, how we use it. And I think it's why maybe we have these kind of drugs may be very active, but if it's only in 1 or 2 or 5% of the patients, it would be very difficult to catch it from large unselected patients population. And it's why it's very difficult if we look at all the development of the immunotherapy, the second generation of immunotherapy we have in hand, because we want to be able to provide the patient with a solution as soon as possible. But we have to understand what is the biological background for using these drugs. And it could be very different from one tumor to another one and from one patient to another one.
Exactly, yep. So the next one that we had teed up here, and maybe we don't need to discuss it in depth necessarily, but this was a drug called BI 754-111. This is similar to the BMS approach in that it's a LAG-3 monoclonal antibody doing a PD-1 combination. We saw some very early phase 1 results here, and I think really the main takeaway was that, similar to the path that the research group at BMS is going down, that this antibody approach is active and is something that could be worth pursuing. So we'll look forward to some of the additional data from this approach once it advances in the clinic. But in the interest of time, Dr. Barlesi, would really be curious for some of your conclusions and interpretations of this study here with the eftilagimod alpha. This is the soluble LAG-3 fusion protein, and some of these very interesting results that we were seeing in frontline lung cancer as well as second line head and neck cancer. This was data that we saw from your colleague, Dr. Philippe from Spain. There was some of this initially presented at the AACR meeting, and now we see it at ASCO as well.
Yeah, I think it's one of the also a good example of, I would say, targeting the potential mechanism of resistance as soon as possible. And we can see that if we look at these two different cohorts, the risk of primary resistance seems to be quite low. Few patients are primarily progressing, especially in the non-small cell lung cancer population, so a little bit more in the head and neck patients population. But in the vast majority of the cases, we can see that we have some long-lasting stabilized disease or patients in response. And we can say, of course, that the number are very small. Then I don't know if the percentage have any sense in this setting. But when we look at the response rates with the combination, if we take the example of the lung cancer patient populations, 53% of partial response is something that we have not seen with a lot of strategies in this setting. Then clearly it highlights once again, it possibly highlights once again that if we are able to target different checkpoints very early, probably the number of mechanisms of resistance that have been activated by the tumor are probably lower, and then it may translate in a better activity of the drug we are giving to the patients. Then I think that it's the first point. The second point will be to try to identify the potential predictive biomarkers for the use of this drug. And it would be also very interesting to try to understand what will be the mechanism of resistance to these kind of drugs, how the tumor will be able to, will try to overcome the activity. But for the moment, the results are very, very encouraging. And if we keep in mind the first table you showed, I think that there is a good relationship between the activity of the drugs and I would say the adverse event, then translating that something happens with these drugs, and it's translating the potential of this kind of immune checkpoint inhibitors.
Got it. Great. Thank you. Thank you for that overview. So then, I guess in terms of just concluding with some final thoughts on LAG-3 here, you know, I guess these different approaches, they're quite different in terms of you know, MHC agonists versus antagonist molecules. Would just be curious, kind of in your mind, how do you think about these different things? Do you compare these at all, given that they sort of act on the same target, or do you think of these as two distinct types of approaches? And then, you know, where do you see this LAG-3 class just moving forward in general?
I believe this class will move forward in general, clearly. Probably, I don't know if all of these drugs will be developed in the phase 3 setting. We have seen that some of them are already in the phase 3. I think for the moment it's very difficult to cross compare those drugs because the type of patients included in these small trials are very different, and probably we'll be able to draw a conclusion only in saying the phase 3 results. But I think it's quite encouraging regarding the activity of those drugs, but we have to keep in mind all the phase 1 or 2 studies we have seen in the past with I would say intriguing or promising results that in fact turn out negative in the phase 3 setting. Then it's very exciting. It's one of the targets we have to follow, but for the moment it's difficult to bet on a potential winner. And regarding the safety, as you have seen in the table and at the beginning of the LAG-3 part, I think there are great differences across the tumors, and the safety profile and the rate of grade 3 adverse event is really different. And I think that we have to look also carefully at the safety profile of these drugs before moving them into the clinical routine.
Got it. Okay. Thank you for that overview then. So the last topic that we wanted to get on, and then we will open up to the audience and have a bit of a broader general discussion, is just this idea of this class of IO bispecific antibodies. So one of the themes that we covered here was that there are several immune checkpoints that can be targeted both directly on T cells, targets that are both on the adaptive as well as the innate immune system. And I guess the general idea with bispecifics is that you know, you can design these molecules that hit two targets at once. That you might have you know, two is better than one type of idea here, and perhaps realize unique benefits of hitting both within the same molecule here. So it's quite interesting, and we selected out 3 of these to just kind of go over and have some of your thoughts on. Actually, the first one that we have here is actually a LAG-3 as well, where it was this is a LAG-3 and PD-1. They call it a bispecific DART molecule. So would be curious, Dr. Blazy, your thoughts here. And then they also showed some other interesting results. These are the monotherapy results. They showed a HER2 combination results as well, that if you have any perspectives on that, we would be curious to hear as well.
Yeah, I think it's a class of drug that we have to follow for sure. I'm not a drug developer, but I heard from my colleagues that it seems to be, I would say, quite easy to do this kind of bispecific antibodies, and even they can do 3 specific antibodies. Then I think given the number of checkpoints or the number of targets we have to address in the field of immuno-oncology, it's something that is very appealing if we consider that we may be able to give only one molecules instead of the addition of 2 or 3 different molecules to our patient. Then giving this drug, it was once again a phase 1, then highly selected populations, a first of human study. But if we look at the results, we can see that there are some responses and even some deep responses, especially in ovarian and lung cancer patients. Then it's I would say it translates the fact that there could be an activity, and especially in these patients populations already pre-treated. The problem is that we have mainly to focus on the I would say the efficacy is just just a signal that provide this the phase 1 studies. We have to focus on the safety profile, as you can see on the left, and it's a drug with some potential side effects, especially if we look at the liver side effects or pancreatic side effects, pardon me. And secondly, it's very difficult to know if the activity is related to the fact that the drug is targeting both PD-1 and LEG-3, and if it's not something that is just, I would say, by chance regarding the activity of one or the other of the target. Then it's this class of drug is very interesting, but it's one piece in the development of the bispecific antibodies. It's one piece regarding the targeting of these two checkpoints. We have to put our attention on the safety profile, but some sign of activity are there, and we have to look carefully on how we can select our patients for that.
Yeah, and Dr. Bellizzi, one of the interesting features here was, as you mentioned, there were some interesting responses seen in patients who had previous checkpoint inhibitor exposure. Is this something that you look at when you're interpreting these studies, or how do you sort of read into that at all?
Sure. I think it's something that is very important. But if we look at our patients with who previously received checkpoint inhibitors, it's also an heterogeneous population. We have some patients who progress very early. We have some patients who had secondary resistance after quite long sensitivity to the drug. And it's very difficult to, we have to look carefully at all the characteristics of the patients, especially those who responded to these drugs and who were pre-treated. But as you can see on the left of the waterfall plot, you can see that we have also some patients already pre-treated with checkpoint inhibitors who progressed on this new drug. And the second point is that we don't have any, I would say, any clear or large idea on the mechanism of resistance on immune checkpoint inhibitors for our patients. Then we believe, because we have seen a lot of time this cycle of the immune system, that we believe that all the mechanisms of resistance are equally distributed in our patient, but we cannot be sure that it is true, and it may be that only, I would say, the impact of LEG-3 may be involved in only a few percentage of our patient, and it's why I think it's very important to try to biopsy and rebiopsy all of our patients in clinical research programs in order to better draw the distribution of the mechanism of resistance, and then design the trials adequately regarding the probability for them to respond to a type of drug or another one.
Right. It's almost that idea of, when you're developing a novel IO drug, it's that question of for who and for what, right? Like, which are the patients that need this and what is the benefit? And it's these biopsies and other translational elements that could get us towards some of those answers.
Yeah, clearly, I think that we did these progresses when we discussed the targeted therapies, and now we have to do that for immunotherapies.
Great. So then the last two pieces of data that we just wanted your quick thoughts on were, two other, dual IO bispecific approaches. One was this early stage data on this molecule called ATOR-1015. It's a CTLA-4 and OX40. So the idea of hitting two IO targets. And then the last one that we'll look at is this drug called IBI-318. And we were quite intrigued. It's a PD-1, PD-L1. So maybe we put to rest the argument of which is better by just having both PD-1 and PD-L1. But it would be great to start here with the ATOR-1015, Dr. Nahir. Your thoughts on this very early stage data set, but just whether you think this is promising and whether this is another promising agent in this broader idea of novel IO bispecifics.
Yeah, I think looking back at the, I would say the preliminary or the earlier results that we have with the OX40, I think that it was quite a little bit disappointing. Then it's interesting to see that combining these two targets, in fact, some of the patients presented with very long-term, very long-lasting, responses, and we have to see more, I would say, carefully the type of patients, the characteristics, and how they potentially responded to the previous treatment and the previous checkpoints they received. But there is a sign of activity. It's once again, I would say, exciting, especially given the results that we had in the past with the OX40 agonists. But it's very preliminary. One of the good points is I would say, the safety profile of the drug. The number of infusion-related reaction is quite high, 33%. But otherwise, it seems to be quite well tolerated. But of course, the numbers are very, very small, obviously.
Got it. Yep. And then the last one that we had here is this very interesting idea of a PD-1, PD-L1 bispecific approach. And again, a very early data set. So perhaps in addition to just your general thoughts on this, would be curious to just understand from your perspective, when you're looking at these very early, phase 1A dose escalation results, are there any key features of the data that you look at in your interpretation to say that, oh, based on this, or if I see this in a very early data set, even though it's very early, I see that as a potentially promising thing? Just curious your thought process on reading through and interpreting, especially the very early data sets.
There was, I would say, some hypotheses regarding the interest to block both PD-1 and PD-L1 at the same time. And if I'm correct, there was some studies regarding the combination of PD-1 and PD-L1's antibodies. Then designing a bispecific antibody is I would say, makes sense. If we look at these results, it's once again very small number of patients. We don't have, I would say, a large description of the characteristics of these patients. They got, I would say, a drug that is, I would say, quite well tolerated. Nothing unexpected regarding the use of immune checkpoint inhibitors. Regarding the responses, they have I would say, approximately 20% of their patients who presented with some level of response, which is interesting, but I would say probably maybe not really superior of compared to what we can expect with just one drug. But once again, we don't have the characteristics, we don't have the PD-L1 expression, we don't know exactly the tumor types. Then I think it's it's very difficult to draw any conclusion. I would say globally, I'm not sure that the main progress we will make in the future will be based to this double inhibition, but maybe in some patients it will be important.
Got it. Yeah, and still very curious and interesting to see just what these different molecules are that people are putting together, where you can kind of almost mix and match and combine these different elements of immune antagonists. So I guess with that, that concludes this data overview of these 4 broad topics that we wanted to go through of TGF-Beta, TIGIT, LAG3, and IO bispecifics. So thank you for going through that with us, helping us sort of think about how to interpret and understand these data sets. And then with that, we really wanted to open up to some discussion and Q&A. We have several questions that different members of the audience have sent in, both in real time and ahead of time as well. So we'll open it up for some Q&A. And I believe Anne, my colleague, will start with some questions.
Yeah, absolutely. So the first one we want to talk about is pretty broad. After we've looked at these various MOAs, they're all very early stage, but they have very exciting data. What stands out to you here? What is sort of the message that our colleagues who might not be quite as deep in the weeds could take away in terms of which of these MOAs is most exciting, or is there a particular patient population where you think there's a lot of promise, just sort of at a headline level?
For me, I would say that a few years ago, we had the first results with the immune checkpoints inhibitors. I would say mostly the theoretical presentation of all the potential targets that we may have in the future. And now we are seeing the first, I would say, we are seeing a large panel of drugs targeting this potential part of the tumor microenvironment. And it's interesting to see that we may now touch we can see the first results of this with the use of these drugs. The second point is that we have a sign of efficacy, and I would say that for the vast majority of the drugs we have presented today, there are some signs of efficacy, but it seems that the increase in the potential of response is maybe marginal, with the exception maybe of the TIGIT combination. And for me, translate the fact that these drugs are active in probably a small part of our patient, because the mechanism of resistance are probably very very important, and we have to identify it in order to be able to draw a precise strategy for a patient based on these drugs.
That makes sense. And I think that's one of the questions when we think about IO resistance. Some patients are going to be refractory from the beginning. Their disease is never going to respond to IO. Other patients might have an excellent response for years, but eventually progress. Are there any MOAs where the initial data suggests to you that they might be more appropriate for those initially refractory patients versus being used in patients who had a good response but eventually stopped responding?
Of course, it's two very different situations. The challenge for those patients who are, progressing who are primarily resistant to the immunotherapy is, I think, very difficult to address. If we look at one of the extreme of this situation, who are the hyperprogressors, we know that they have a very short overall survival after progressing on immunotherapy. Then I think that we still have probably to understand what is the basis of these primary resistances. And probably for those patients, the combination with more standard approach with immunotherapy will probably remain important in the future. For those who responded, I would say, in some extent to immunotherapy, either with a prolonged stabilized disease or a response and then a reprogression. We know that the features of the progression are also highly variable, with some very slow progression, and it seems that we can target those mechanisms with sometimes local treatment, and I think we have to rethink our use of local treatments in these situations. And also, if we are able to identify either in the blood or by doing a tissue biopsy the mechanism of the resistance, or at least have a better idea on that, then we may be able to add something. Then it's very different, and I would say the first sign that we have from the data already presented is suggesting that for those patients who responded at the beginning to the treatment, there could be a chance for a new response, probably greater than for those patients primarily resistant.
Got it. And then, Dr. Barlesi, I know in medicine we try not to speak in hyperbole or too enthusiastically before the data is there, but I believe the question just needs to be asked. So many are saying that once we saw this TIGIT data and then, very rapidly going into phase 3, people are saying, oh, TIGIT is the next big thing. Do you agree? I guess just curious, what would you say is the next big thing when we talk about the next wave and the next generations of immunotherapies beyond PD-1, PD-L1?
I think I don't know if it's the next big thing, but for sure it will be the most expected next results. Then we'll look at this target. We have seen a lot of phase 2 with very exciting results that unfortunately did not translate it in a clinical benefit in the phase 3. Then I think we should be probably prudent in interpreting these results, and especially I would say not within scientific or medical discussions, but especially when discussing these results and presenting those results to the patients or the public, because I think we are generating a lot of hope regarding patients who resisted to the immunotherapy, and we have to look carefully to the message we are delivering to the general population. But I think there is a sign, and if we are able in the translational part of the trial to understand the patients' populations deriving the greater benefit outside the PD-L1 status, then clearly it will become one of the stars of the IO in the future.
Got it. Yeah.
So Dr. Barlesi, as we saw the CTLA-4, PD-1, PD-L1, now we are seeing the next wave. Obviously, colleagues and you, we have been waiting for a little while to see where the next wave was going to come from, and we saw some ideal experiences as well. What are some of your advice for the colleagues out here in terms of how to select patient selections, trial design, trial size, rational combinations, so that we can start small to see are there signals that we can incorporate and translate into broader trials, so that we don't have more of these ideal experiences and more of successes?
I would say that if we are discussing the clinical trial setting, if I correctly understood your question.
Yeah. Mm-hmm.
I think that for the moment, we have so many things that we do not understand that we have to do the comprehensive workup for those patients, I would say, the best we can. We have to take tissue. We have to take to analyze those patients completely, to collect the data regarding the characteristic of these patients as completely as possible. Also the concomitant drugs they use, they receive even in the, I would say, in the previous months of the before the diagnosis. Also look at their general characteristics, and that I would say it's likely that the efficacy of the immunotherapy will be explained in the future, both regarding the characteristics of the tumor, but also the characteristics of the patients. And we have to better understand the place of these two types of factors. I can think to the microbiota also, that and we don't know how we will implement this kind of analysis in the future in managing our patient, but it may have a big place in driving the use of them. And I would say, when designing a trial, I will do a workup as comprehensive as possible. The second point will be to monitor those patients the best we can. I would say, regarding also what we can do on liquid biopsies, we can follow the circulating tumor DNA levels. We can follow a lot of different blood biomarkers. And I think it will be very important to identify as early as possible patients who benefit from the drug or the combination or the strategy compared to the other one, in order to be able to adapt our strategy as early as possible. Because I would say that my feeling is, or my experience is, that when a patient is escaping from the strategy in place, it's very difficult to overcome and to rescue the patients when they are progressing quite early after the initiation of the treatment. And I think it will be important to have tools in our hand and tools within the clinical trials that allow to identify patients who are not benefiting from the treatment. I will also try to monitor the patients with, I would say, innovative imaging techniques. We know how artificial intelligence may help to interpret even simple radiological data like CT scans, but we also know that we have many possibilities regarding metabolic imagings. Then it's something that will be also very important in the future, probably, to use all these tools to identify before treatment, but also on treatment, how the drugs is working, especially if we consider that there is a tumor heterogeneity and we are not able to face this tumor heterogeneity with a tissue biopsy and biopsy of all the components of the tumors.
Thank you for that.
Great. So then, Dr. Borlase, just to sort of wrap up here, would be curious to understand, with the way that IO is moving and we have all of these different targets that are in development, what do you think the biggest shift will be between today and, let's say, 3 years from now, ASCO 2023, we're having the same discussion? What do you think will be the biggest needle movers that we will have seen between now and then?
Of course, it's a dangerous question, and probably if you show me this data in 3 years from now, you would say, "Oh, what you said just in 2020." I think it is clearly impossible. But I think that I think there will be both possibly de-escalation for some patients who will be the patients with the highest probability of response. And if we are able to identify early those patients, maybe we will need to have, I would say, like an aggressive strategy at the beginning, but for a very short time, and then a very simple maintenance treatment with maybe less infusion of the drugs, maybe every 3 months, maybe 6 months for some of the patients. That there could be some de-escalation. And conversely, there will be some escalation in the type of combination in some patients. It may be based on newly available drugs. It may be based on new types of drugs like the bispecific antibodies we have seen. It may be based on the combination with local treatment also that may provide long-term benefits for those patients with only stabilized disease, as an example. And I believe that this escalation will be also in 3 years from now driven by better knowledge about the tumor microenvironment and how we can assess this microenvironment, both in the tissue biopsy we are doing on a regular practice, but also into the blood. I really believe that blood will provide us probably with a lot of information in the future. And I also believe that the patient's characteristics, will it be the co-medication, the past medical history, the treatment you received in the past, the microbiota, other things will be important. And to finish, I would say that maybe going directly into the tumor may be also one of the potential innovative strategy that we may choose in the future with especially the development of all the intratumoral immunotherapies. And we have trials activated, and it may provide a solution to overcome the risk of primary resistance.
Great, thank you.
Wonderful. Well, thank you so much, Professor Barlesi. We really appreciate you taking the time to speak with us this afternoon. Any other closing thoughts, things you wanted to make sure you got the chance to say before we let you get on with your afternoon?
I have to thank all of you for organizing this meeting. I would say that it's really important also to exchange and to share our experiences because clearly the science now is clearly global, and we all develop. We all have our intuitions, our hypotheses. We all develop innovative strategies in this field, and it's very important to share the results, even if it's a failure regarding our expectation. But I think it's very important to provide the scientific community with all the different types of results we have, and also to be able as early and as quickly as possible to confine potential change in our understanding of the disease and their management regarding immunotherapy. We have the possibility to do a large trial with in a quick way. Then I think it's very important to try to confirm as quickly as possible the good sign that we made derived from small studies, as we have seen today, because the patients are clearly waiting for progresses in this field on the basis of what they see in the 20% rate of patients who are benefiting for long-term efficacy of immunotherapy.
Wonderful, thank you. Well, we couldn't agree more that communication and discussion of these ideas is so important right now, especially as we're all located in different places. So thank you again for your time. And just as a reminder, this session will be available on the Axiom Healthcare Strategies YouTube channel. So Professor Barlesi, if you'd like to look back at it, or anyone else who wasn't able to join us today, please take advantage of that over the next week. So thank you.